Silent but spreading. Sierra Leone's cutaneous ulcer outbreak exposes deep cracks in rural health care. Good day to you, wherever you are watching us from. This is BAV Inside Salone, and I am Isatu Kamara-Kargbo. Today, we turn our focus to a public health development unfolding in northern Sierra Leone, one that demands calm, clarity, and context rather than fear or misinformation. On Friday, January 9th, 2026, Sierra Leone's National Public Health Agency, NPHA, in collaboration with the Ministry of Health, MOH, issued a joint statement confirming an active outbreak of cutaneous ulcers in Bombali District, specifically within multiple communities of Safroko-Limba Chiefdom. According to the official release, the spread was first detected in the Kayasik community on November 17, 2025, and has since affected 267 people across 27 communities, with children between the ages of 5 and 15 bearing the brunt of the infections. Of these suspected cases, 96 have been laboratory confirmed, 150 patients have recovered, and, crucially, no deaths have been recorded so far. These figures are drawn directly from the NPHA-MOH Joint Situation Update issued on January 9, 2026. Health authorities have identified the cause as Haemophilus ducreyi, a bacterium more commonly associated in global medical literature with tropical skin ulcers in low-resource settings. The disease presents with painful skin ulcers, typically on the arms and legs, swollen lymph nodes near the sores, and mild constitutional symptoms such as fatigue or low-grade fever. Despite the discomfort involved, officials stress that no severe cases requiring hospitalization have been reported to date, an important reassurance that differentiates this outbreak from more lethal epidemics Sierra Leone has faced in the past. The data also shows a slight male predominance, with boys accounting for about 56% of infections, a pattern consistent with exposure-related skin conditions in rural settings, where children, especially boys, are more likely to sustain minor cuts and abrasions during play, farming assistance, or outdoor activities. This epidemiological detail, again, comes straight from the NPHA's outbreak briefing. At the center of the response is Fode Sarr, Executive Director of the National Public Health Agency, who has publicly assured Sierra Leoneans that the outbreak is under control. According to Professor Sarr, the NPHA has activated comprehensive response protocols, including community-based case management, clinical care at peripheral health units, environmental decontamination in affected villages, and targeted training for healthcare workers on wound care and hygiene practices. These measures mirror containment strategies recommended by the World Health Organization for similar non-fatal skin ulcer outbreaks in sub-Saharan Africa. Now, to place this development in a wider African context, it is important to note that cutaneous ulcer outbreaks linked to Haemophilus ducreyi are not unique to Sierra Leone. Similar clusters have been documented in Ghana, Papua New Guinea, Vanuatu, and parts of Côte d'Ivoire, often in rural communities with limited access to clean water, sanitation, and early medical intervention. In many of these countries, delayed detection allowed minor outbreaks to persist quietly for years, leading to stigma, school absenteeism, and long-term scarring, especially among children. What stands out in Sierra Leone's case, however, is the relatively early detection and public disclosure, a sharp contrast to earlier eras when outbreaks were often underreported or politicized. The NPHA's decision to release case numbers, recovery rates, and laboratory confirmations reflects a post-Ebola public health culture that prioritizes transparency and community engagement, an institutional lesson hard-earned during the 2014-2016 Ebola crisis. Yet even as authorities project confidence, this outbreak raises forward-looking questions that Sierra Leone, and Africa more broadly, cannot afford to ignore. Why do preventable skin infections continue to disproportionately affect rural children? How resilient are district-level surveillance systems once donor funding cycles end? And are environmental health interventions, clean water access, sanitation, and basic hygiene education being treated as long-term investments rather than emergency add-ons? The NPHA has urged residents in affected communities to report suspicious skin lesions immediately, wash hands frequently, keep wounds clean and covered, and avoid sharing personal items such as towels, sponges, or clothing. These recommendations, outlined verbatim in the agency's public advisory, also call on citizens to cooperate with community health volunteers and adhere strictly to infection control measures currently in place. At the same time, health officials confirm that 201 close contacts are under active follow-up, a key containment strategy designed to prevent silent transmission within households and schools. This approach aligns with best practices seen in successful containment efforts in countries like Rwanda and Senegal, where robust contact tracing, not just during pandemics, but for localized outbreaks, has become a permanent feature of public health governance. As Sierra Leone awaits further updates promised by the NPHA, this situation serves as both a test and an opportunity, a test of decentralized healthcare delivery in rural districts, and an opportunity to strengthen disease surveillance beyond crisis moments. The agency has encouraged citizens seeking more information or wishing to report suspected cases to contact their nearest health facility, underscoring that community trust and early reporting remain the strongest defenses against escalation. And as we continue to monitor developments from Bombali District, one thing remains clear. This outbreak is not just a health story. It is a mirror reflecting the state of rural health infrastructure, childhood vulnerability, and Africa's ongoing struggle to shift from reactive to preventive public health systems. Because when we talk about outbreaks like this, we are also talking about systems, priorities, and political will. What is unfolding in Bombali District forces us to confront a familiar African paradox. Diseases that are clinically manageable continue to spread, not because science has failed us, but because structural gaps remain unresolved. In many rural districts across Sierra Leone, and indeed across much of sub-Saharan Africa, minor skin injuries often go untreated for days or weeks. Children play barefoot, fetch water from open sources, and share household items in crowded living conditions. In such environments, bacteria like Haemophilus ducreyi find fertile ground, not because they are particularly aggressive, but because early intervention is often absent. Across the continent, similar outbreaks have followed the same pattern. In northern Ghana, localized skin ulcer clusters among schoolchildren persisted for years before being formally classified and treated. In parts of Côte d'Ivoire, delayed reporting turned manageable infections into chronic public health burdens. Even in countries with stronger health indicators, such as Kenya, outbreaks of neglected tropical skin diseases have exposed the uneven reach of primary health care beyond urban centers. The lesson is consistent. Where community health surveillance is weak, small outbreaks linger and quietly erode quality of life. Sierra Leone's current response shows progress, but it also highlights unfinished business. While community-based management and environmental decontamination are welcome steps, public health experts warn that short-term containment without long-term prevention risks recurrence. Clean water access, improved sanitation, routine school-based health screening, and sustained hygiene education are not emergency measures. They are development fundamentals. Without them, today's controlled outbreak can easily become tomorrow's seasonal norm. There is also the question of health equity. The fact that the majority of cases are children between 5 and 15 years old is not incidental. School-aged children in rural chiefdoms often fall through the cracks of healthcare delivery. They are old enough to be outside maternal and child health programs, yet too young to advocate for themselves when symptoms begin. In several African countries, forward-looking reforms have addressed this gap by integrating school health programs into national disease surveillance frameworks, an approach that Sierra Leone may increasingly need to consider if it hopes to move from reaction to prevention. International guidance from institutions such as the World Health Organization has long emphasized that neglected skin diseases thrive where poverty, overcrowding, and limited access to care intersect. The Bombali outbreak fits squarely within that framework. While Sierra Leone has demonstrated improved outbreak communication since the Ebola era, the deeper challenge lies in translating that transparency into budgetary commitment, especially at district and chiefdom levels where outbreaks actually begin. Another forward-looking concern is data continuity. The current figures, 267 cases, 96 laboratory confirmed, 150 recoveries, provide a snapshot in time. But public health is not governed by snapshots. It is governed by trends. Will surveillance remain active once media attention fades? Will contact tracing continue until transmission chains are fully broken? And will lessons from Bombali be systematically applied to other districts with similar risk profiles? Equally important is the role of community trust. The MPHA's call for cooperation with community health volunteers is not a procedural footnote. It is the backbone of outbreak control. Across Africa, from Senegal's cholera response to Rwanda's measles containment strategies, outbreaks have been halted fastest where communities believed the system was acting with them, not on them. Mistrust, misinformation, and stigma remain powerful accelerants of disease spread, particularly when skin conditions are involved. As we continue to assess the situation in Bombali, one cannot ignore the broader warning embedded in this outbreak. Health security is local before it is national. No matter how strong policies appear in Freetown, their true strength is measured in villages like Kayasik, where a child's untreated wound can quietly become a public health statistic. And so, as authorities promise regular updates and residents are urged to remain vigilant, this outbreak continues to raise deeper questions, not only about bacteria and treatment protocols, but about how prepared Sierra Leone truly is to protect its most vulnerable citizens before preventable diseases gain a foothold. Because preparedness, in the end, is not measured by statements issued during an outbreak, but by what exists long before the first case is detected. This is where the Bombali situation intersects with a much broader African challenge, the underfunding of primary healthcare as a first line of defense. Across many countries on the continent, national health budgets still lean heavily toward tertiary care and emergency response, while preventive and community-level systems remain chronically weak. Sierra Leone is no exception. While the country has made commendable strides in epidemic response capacity since Ebola, particularly in surveillance coordination and laboratory diagnostics, the everyday realities in rural chiefdoms continue to lag behind policy aspirations. Consider the issue of water, sanitation, and hygiene, WASH. Cutaneous ulcer outbreaks thrive where access to clean water is inconsistent and where wound care materials are scarce. In Bombali, as in many rural districts, families often rely on shared water sources, and children frequently clean wounds with untreated water or improvised materials. Without sustained investment in basic WASH infrastructure, health education alone becomes an uphill battle. This is a structural vulnerability not unique to Sierra Leone, but one that has repeatedly surfaced in rural communities from Liberia to Malawi. There is also a human resource dimension that deserves closer scrutiny. Training healthcare workers on wound care and hygiene, as the NPHA has rightly emphasized, is essential. But training must be continuous, not episodic. High turnover among community health workers, inconsistent stipends, and limited supervision undermine the long-term impact of such interventions. In countries like Rwanda, retention and professionalization of community health workers have proven critical in sustaining disease control gains. Sierra Leone's response will be judged not just by how quickly this outbreak subsides, but by whether frontline workers remain equipped months from now. Another underexplored layer is the social cost of outbreaks that are labeled non-severe. While officials correctly note that no hospitalizations or deaths have occurred, painful skin ulcers still carry hidden consequences: missed school days, stigma among peers, reduced mobility, and long-term scarring. For children between 5 and 15, these impacts are not trivial. In several African countries, untreated or recurrent skin diseases have been linked to school dropout and reduced educational performance, quietly reinforcing cycles of disadvantage. This is why agencies such as UNICEF have increasingly framed childhood skin infections, not just as medical issues, but as child protection and development concerns. From that perspective, the Bombali outbreak becomes part of a larger conversation about how public health intersects with education policy, rural development, and social services, areas that are too often siloed in African governance structures. Looking ahead, the key question is whether this moment will trigger institutional learning. Will Sierra Leone integrate routine skin disease screening into school health programs? Will district surveillance teams receive stable funding beyond the emergency phase? And will data collected in Bombali be used to proactively map other high-risk chiefdoms before similar outbreaks emerge? There is also the matter of public communication discipline. The NPHA's commitment to regular updates is encouraging, but consistency will matter. In past African outbreaks, whether cholera, Lassa fever, or measles, initial transparency has sometimes given way to silence once case numbers plateaued. That silence creates space for rumors, misinformation, and public complacency. Sustained communication, even when the news is no change, is essential to maintaining vigilance. Ultimately, what Bombali is showing us is that health resilience is built slowly and tested suddenly. The bacterium at the center of this outbreak is not new, nor is the science required to manage it. What is being tested instead is the depth of Sierra Leone's public health foundations, from village-level hygiene practices to national budget priorities. As contact tracing continues, recoveries are monitored, and environmental decontamination efforts expand, the outbreak remains contained for now. But containment is not the same as closure. The real measure of success will be whether Sierra Leone uses this episode to close long-standing gaps before the next preventable disease finds another vulnerable community, because closing those gaps is where leadership, citizenship, and accountability finally converge. For African leaders watching developments in Bombali District, this outbreak offers a clear warning and an equally clear roadmap. Health emergencies do not always arrive with dramatic fatalities or international headlines. Sometimes they emerge quietly, in children's wounds, in overlooked villages, in diseases labeled non-severe. Yet history has shown us time and again that today's neglected outbreak can become tomorrow's national crisis if structural weaknesses are ignored. Leadership, therefore, must move beyond reassurance to institutional reform. Governments across Africa, including Sierra Leone, must treat primary health care, WASH infrastructure, and community surveillance as core national security assets, not peripheral social programs. Budgeting for health should not spike only during emergencies and collapse afterward. District health systems need predictable funding, trained personnel with job security, and data systems that remain active even when the cameras leave. At the same time, African leaders must resist the temptation to centralize health narratives while decentralizing responsibility. Outbreaks begin locally, but they are prevented nationally. Policies crafted in capital cities must translate into soap, clean water, wound dressings, and trained hands in rural communities. Without that translation, progress remains theoretical. To African citizens, the message is equally important. Public health is not the sole responsibility of ministries and agencies. It is a shared civic duty. Reporting symptoms early, adhering to hygiene guidance, cooperating with community health workers, and rejecting misinformation are acts of collective protection. Silence, stigma, and delay are often more dangerous than the disease itself. Parents, guardians, and community leaders, especially in rural areas, must recognize that small wounds deserve serious attention. Early care prevents prolonged suffering. Schools, religious leaders, and local councils all have a role to play in reinforcing hygiene practices and encouraging prompt medical consultation, particularly for children who may not speak up about pain. And finally, to policymakers across the continent, the Bombali outbreak underscores a fundamental truth. Africa does not suffer from a lack of medical knowledge. It suffers from gaps in implementation. The tools to prevent and control diseases like cutaneous ulcers already exist. What remains is the political will to apply them consistently, equitably, and sustainably. Key takeaways. The Bombali cutaneous ulcer outbreak is under control, with no deaths reported and active response measures in place. Children in rural communities remain disproportionately vulnerable due to structural gaps in hygiene, surveillance, and early care. Transparency and early reporting represent progress, but long-term prevention requires sustained investment, not emergency action alone. Africa-wide comparisons show that neglected skin diseases thrive where primary healthcare is weak and prevention is underfunded. True health security depends on strong community systems, informed citizens, and accountable leadership. As Sierra Leone continues to monitor the situation and issue updates, the broader lesson for Africa is unmistakable. Public health resilience is built before the outbreak, not during it. What happens next, after the ulcers heal and the numbers stabilize, will determine whether Bombali becomes a footnote in progress or a warning unheeded. Health crises do not begin with death counts. They begin with neglect. If Africa is serious about prevention, equity, and resilience, then stories like Bombali must be treated as warnings, not footnotes. This has been BAV Inside Salone. Like, share, subscribe, and stay bold, because Africa's future depends on informed citizens and accountable leadership.